What's up with all the non-MD providers practicing medicine these days? You've got your DOs, your nurse practitioners, your PAs, all of these people serving in the role as a physician. Does this make any sense? Well, talk about a minefield. When I made this video, I knew I'd be stepping into one, and so I consulted an expert resource, the Army Corps of Engineers Field Service Manual for Minefields and Booby Traps, 1943. Turns out there's two basic ways to navigate a minefield. First, you can get one of those minesweepers, and you can very carefully and gingerly make your way through the minefield. The other thing you can do is get a bulldozer. Put a big attachment on the front and just plow through and blow up all the mines. That's the approach I've taken in this video. But if you go back 3 generations, things were a lot simpler. Back then, only MDs were practicing medicine. There were no PAs, there were no nurse practitioners, and you didn't see too many DOs either. And back then, I smoked Camels, because more doctors smoke Camels than any other cigarette. And I'd like to take this opportunity to thank the sponsor of this video, the R.J. Reynolds Tobacco Company. Let's be clear on this point. The gold standard is still an MD physician, board certified in internal medicine or family medicine, who has done all of his or her training in the United States or Canada. Right now, only about 40% of PCPs have that educational background. Why should we consider any of the alternatives? Well, beyond the obvious that there just aren't enough doctors to go around. Well, it turns out that things are not exactly what they seem. Training programs in internal medicine and family medicine are the residencies of last resort. You can be at the absolute bottom of your class in medical school and still get a residency in one of these fields, but you're never going to be a dermatologist or a plastic surgeon. Sure, places like UW and Virginia Mason, they're always going to get their fill of top-notch medical students. But these are internationally renowned institutions. Now, if you're the family medicine residency program that Providence runs down in Olympia, well, for many years they've never been able to even fill their entire class with warm bodies. All other things being equal, people would rather see an MD physician. But unfortunately, all other things are never equal. Would you rather see a nurse practitioner who trained at Hopkins, top of her class? Or some guy at the bottom of his class in medical school who did his residency in Yakima? Residency is only half the story. Now, if your doctor went to a medical school with the name American in it, well, I can pretty much guarantee that that school was not located in the United States. There are a number of physicians in practice today who attended medical school in the Caribbean. The Caribbean medical schools are less competitive. So, if you partied way too much in college, went to ASU maybe, joined a frat or a sorority, well, you didn't have the GPA or the MCAT you needed to get into an American medical school. Now, all of those students still have to do a residency in the United States. And there's some really good physicians who've gone that route, but it is nobody's first choice. Some patients get really excited if their doctor went to Harvard or Yale. Well, these places don't produce many primary care physicians, and I've got no science to back this up, but there's a general vibe that the medical students that come out of those programs might have a very good scientific basis for medicine and be good at research, but that they lack common sense. And, well, maybe you could say that for all graduates of their programs. But the fact is that clinical medicine requires a mix of good scientific knowledge, but also common sense and judgment. Sure, there's some cachet if your lawyer went to Stanford. Now, I could never afford a Stanford lawyer. I'd be happy with someone who went to Gonzaga. Actually, there is one Stanford lawyer I could afford, and that's my daughter, but she does antitrust. And let me just say that we've never done any price fixing in our office, and all of our business practices are fully compliant with the Sherman Antitrust Act. Just saying, honey. Some patients seem hell-bent on picking a doctor of the same gender that they are. Personally, I think this is a mistake. A good clinician is going to be able to connect with and look after patients of either sex. Now, in my many years at Med Northwest, I've taken care of a few more women than men, but overall a good mix of both genders. And every physician at Med Northwest has a mixture of men and women in their practice. I just think there are far more important factors that should go into that decision than just matching up on gender. DOs, doctors of osteopathy, sometimes they're confused with chiropractors, but it's not the same thing at all. DOs go through a very similar training process as MD physicians. In both cases, it's 11 years minimum from leaving high school to starting clinical practice. Now, the DO programs are less competitive, so students applying there have lower GPAs and lower MCAT scores, and they're stuck with that DO at the end of their name. But the fact is that the training is fairly similar to that of physicians. One thing for DOs is they learn osteopathic manipulation in DO school, but most of them don't believe in it, and I rarely see anybody practicing it out in the real world. There's also a debate over internists versus family medicine physicians for primary care. Now, if you clone a dozen medical students and send half of them through an internal medicine residency and the other half doing family medicine, when you come out on the first day of practice, the family medicine doctors are going to be better. And they're better because in their residency, they spend much more time in the outpatient setting and much more time doing primary care. The internists are going to be better working in the hospital setting. But if you come back 2 years later, you're not going to find much difference. The fact is that both training programs are good ways to build the foundation to be a primary care physician. On occasion, a prospective patient contacts me and says, I want an internist for my primary care physician. And the reason somebody is asking specifically for an internist is that they believe that an internist is more intelligent than a family medicine doc. And this is correct. All internists are smarter than family medicine physicians. All right, I'm just kidding with you. Yeah, maybe 50 years ago, but I've interviewed tons of physicians in both specialties, and I've worked with them. There's no difference. That's all made up. One thing to keep in mind is that only about 1 in 5 internists go into primary care, and so family medicine physicians are going to make up the bulk of the primary care workforce going forward. The next issue is the practice setting. Now, do you want to see a nurse practitioner who's at Johns Hopkins, or do you want an MD physician who's doing urgent care out in Ritzville? The fact is that the practice setting is sometimes more important even than the clinician you're seeing in terms of raising standards of excellence. Now, I went to medical school in the 1980s, and I've been through more than a dozen hospitals, and I can tell you it's amazing how important the practice setting is in terms of the quality of care you receive. At Med Northwest, we do concierge medicine, so yeah, the practice setting is just about as optimal as it's going to be. And it is true that all of our physicians are board certified, internal medicine, family medicine, residency trained, and went to school in the United States or Canada. But we also have Melissa Kester, a doctorate level nurse practitioner. Now, I've worked with Melissa since 2020, and I know, based upon my close contact with her, that she is practicing medicine at the level equivalent to the top 5% of primary care physicians that I've ever met in my entire life. But I don't know that we can use Melissa as a proxy for all nurse practitioners. Don't put this in the video, but you know what? If my kids need somebody, I'd send them to Melissa. Well, I've stepped on a lot of landmines today, but the conclusion should be pretty obvious. The clinician you're seeing matters much more than where they got their training or the letters at the end of their name. But I hate that conclusion. And the reason I hate that conclusion is it sounds like something some corporate PR consultant came up with, something to tell a patient who calls and is pissed off because they didn't see an MD at their office visit. But it's true. The fact is, clinical medicine requires a talent. A great clinician has a gift. Some people have it and some don't. And I don't care where you went to school or what your degree is. There are great clinicians and then there are mediocre ones, and it comes down to the individual. Okay, sure. If you're on a website and you've got to pick a PCP, choose an MD physician who trained in the United States or Canada and has completed a residency and is board certified in internal medicine or family medicine. Sure, that's the safe bet. Yes, those are the doctors here at Med Northwest. But if you're under the care of a DO or a nurse practitioner or a PA and you're getting great care and you're happy, well, the devil you know is not a devil. It's an angel.
That's good, but let's do another take.
Oh, I don't want to do another take.
Look, you're being totally honest here. People usually don't get that. Don't you want patients to have this kind of information?
Yes, I want patients to have this information. I just don't want to be the one giving it to them. I want somebody else to get all the hate mail. I want somebody else to get all the vitriol. So wait a second here. You're going to let me approve everything before you put it online, right?